Hello, everyone. Welcome to our Thursday webinar. My name is Lourdes. I am a patient advocate with the Foundation. I'm glad that you have joined us today. We have today Dr. Chandana Banerjee. She is the Dean Director and Designated Institutional Official for the Graduate Medical Education at City of Hope. She is also an associate professor in the Department of Supportive Care Medicine, specializing in hospice and palliative care. She has written and published numerous articles and book chapters and spoken at conferences nationally and internationally. She earned her undergraduate degree from the University of Connecticut, her master's degree in public administration from New York University, and her medical degree from Sabah University School of Medicine. In her free time, she likes to write poetry, and she has her second book of poems, Neruda in Bed. It was published in November 2021. We want to welcome you today and thank you for sharing this information with the community. As a reminder to everyone, please feel free to put any questions in the Q&A or in the chat. And if you can please make sure that you keep your questions general in nature, as we cannot answer very specific questions. I'm going to hand it over to you.
Great. Thank you very much to you and to the Cholangiocarcinoma Foundation and to all of you that are here on the webinar today. It is my honor to talk to you about palliative care and actually the enigma of palliative care, because I'm sure for many of you, when you hear of palliative care, as do my family members, they just associate it with the end of life and they don't know what to do with it. You know, often patients are scared when they hear these words, palliative care. They cocoon into not really looking for more information about it. So my hope today is that I can debunk some of the myths that you have about palliative care and give you just a general knowledge of really how it can help you and your loved ones navigate this complex system of healthcare when it comes to dealing with cancer, whether it's cholangiocarcinoma, specific to this foundation, or whether it's really any other cancer. Palliative care is a field that really can bridge so many things for so many people. And my hope is that you find the benefits of the service, which are practically available at many hospitals around the country. Okay, so with that, I'm going to approach it as if we were talking, but just so that people understand some of the nuances, I did create a short PowerPoint. So I'll be speaking through that, and then we will take general questions towards the end of this presentation. So with that, just want to make sure everyone can see my PowerPoint and we can proceed. So the reason I call this, again, the enigma of palliative care is because it's an enigma. It's not a very new field, and often it's really confused for many people with end-of-life care. They don't really quite understand it. So what does really palliative care mean? What does it do for your family? What does it mean when people say, maybe it's time to involve palliative care in your treatment? Okay, what are some of the questions you need to be asking at that point? So these are all important concepts when you're dealing with any kind of serious illness, right? So I have no relationships with industry to disclose. I work at the wonderful City of Hope National Medical Center near Los Angeles, California, where we have robust clinical trials as well as treatments and cures, as well as a wonderful supportive medicine department that I'm associate professor in. And what I thought is to start with, because I'm speaking to you, and you as members of this foundation are far more versed with this than I would be, I just thought, let me just start with a very brief overview of what we're going to talk about. And I want you to take that concept of palliative care and apply it back to the bile duct cancers that we talk about, or your loved ones might be going through, or you yourself might be getting treatments for. So, objectives today, we're going to look at the general summary of bile duct cancers. We're going to define palliative care, not only for the World Health Organization, but in the global scheme of things as humans, which is always important. I like to break it down to our level. We want to define the quality of life because ultimately the goal of palliative care is to improve the quality of life. We want to understand the importance of integrating palliative care in patients with cancer, symptoms that require palliative care, and review really palliative care options at the end of life on a broader scheme. So when you look at bile duct cancers, there are multiple cancers in this family, and these are basically cancers that form in the slender tubes that carry the digestive fluid bile through the liver. The issue is that this cancer is often rare, but aggressive. And because of its rarity, it often is missed early on in diagnoses. The diagnosis is many times late, and when it is diagnosed at the late stages, curing it can make it very difficult. For those of you that are familiar with this cancer, the symptoms can be yellowing of the skin, which is called jaundice. You get itchy skin, you have white stools, and these are all really results of the way your bile ducts are interacting with the liver and things getting blocked up and the appropriate fluids not coming out. So there are various treatment options when appropriately diagnosed in time. And some of the curative options can include chemotherapy, radiation therapy, and even surgery. But what happens when really cure is not an option? There's also something called palliative options. And palliative options are not specifically palliative care medicine, but these are options that can help reduce the symptom burdens caused by your cancer. These palliative options are not meant to be curative options for bile duct cancer. So the options can include stent or catheter placement if there's a blockage. You can have biliary bypass, where you can open the bile fluid tubes into another entity. You can have tumor ablation when a full resection is not possible. Sometimes people even use alcohol injections to really numb the nerve endings to the tumor, where pain and sensations are carried to your brain. So those can be numbed for really a little bit more comfort. So how does this all sit in the whole scheme of palliative care? So we need to understand palliative care as a general. So when we look at palliative care, we first and foremost need to understand that it is not end-of-life care. When we look at end-of-life care, that is hospice care or comfort care, and palliative care is a component of that because some of the elements are very similar. However, palliative care is something that can be applied to a disease or a serious illness right at the diagnosis, and it can be applied until the patient achieves cure, or it can continue beyond that if the patient or the disease does not have a curative option, right? And palliative comes from this word called to palliate, which means to help relieve or alleviate. It does not come from cure. So the World Health Organization has defined palliative care as an approach that improves quality of life for patients and their families facing problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, whether it's physical, psychosocial, or spiritual. And that is the beauty of palliative care. It is a kind of medicine that treats patients with serious illness that can provide a layer of support for them and their families. To jump into it, palliative care is offered on multiple levels. We have primary palliative care where really all specialties in medicine, basic healthcare workers, they all get a foundation in providing basic palliative care to families. Then you have secondary palliative care where you have specialists like oncology, endocrinology, hematology, providing palliative care as well as part of their treatment plans. And then you have really tertiary palliative care, where you have trained physicians like myself and other experts in the field of palliative care medicine that provide palliative care at cancer centers and other high acuity hospitals, working together with the rest of the teams that the patient is following. So in a nutshell, really, palliative care provides relief from pain and other distressing symptoms, right? It definitely affirms life and regards dying as a normal process. So it does not focus on end of life. It focuses on how you live your life when you're going through treatments, how you're facing your disease, and how you plan for the future. It does not intend to hasten or postpone death. And it integrates psychological and spiritual aspects of patient care, which is critically important when anyone is going through treatments or is faced with a serious illness such as cancer. The biggest advantage to palliative care medicine is that it offers a support system to help patients live as actively as possible until death. And one of the things that we have to emphasize, it's not just the patients, but it offers a support system to help the family and the caregivers cope during patients' illnesses and their own bereavement. It can help with something called anticipatory grief if the disease is not curable. It really becomes an integral part of your support system when you can talk to these people in a palliative care team, discuss your fears, discuss your goals, and work with them so that everyone is on the same page. It uses a team approach to address needs of patients and the families. Its goal is to enhance quality of life, but studies have shown that getting early palliative care involved in your disease process has positively influenced the course of the illness. With symptom burdens that are addressed by the palliative care teams, it's easier for people to be less anxious, to be less distressed, and that actually enhances their quality of life. It's applicable anytime in the course of the illness, and we recommend that if you do have a serious illness such as cancer, that you get a palliative care team involved early so that they can walk this journey with you up until the time you're cured. And if cure is not an option, to help you plan for the future. It is really to be used with other therapies that are intended to cure your disease or prolong your life, such as chemotherapy, radiation therapy, and basically manage all these symptoms and the distress that comes with these treatment options. So what is really special about palliative care as a whole, and one of the reasons I enjoy being in this field, is because you're not working as a solo doctor. As a physician in palliative care, as a palliative care doctor, you're working with the entire palliative care team. And we're lucky that we're one of the fields that actually avails that to our patients. Who really makes up this team? So if you go to most centers, your palliative care team will have a doctor that's specialized in palliative medicine. You'll have a nurse that's often specialized in palliative medicine. You for sure will have a social worker that works with you. You will have someone from the spiritual care team. You can have psychiatry and psychology involved, and you can have child life specialists involved. Now, do you have to have all these team members with you? Not necessarily, but having a palliative care team allows you to pull in whichever member of the team you need most at that particular point in your disease process or in your life. So that's the whole idea of getting a palliative care team, getting a palliative care consult early on in the process. So really looking at the palliative care team, by working with the team, palliative care can help in the following ways. So it can have great help in management of symptoms of the disease. Because as you know, with bile duct cancer, as with other cancers, not only are the symptoms of the disease sometimes very difficult to handle, but sometimes the side effects of treatments are also difficult to handle. If you think of things like radiation therapy that causes mouth sores, that causes depression, causes anxiety because of the fact that you may get mouth sores. You have palliative care as a team working together to sort of help you cope with these issues and resolve them or alleviate them if you can by medicine. Management of stress, anxiety, and other psychological trauma, including coping skills, are a huge skill set employed by palliative care teams. The other thing that palliative care teams can do is that they can help you match your treatment options with your goals. Let's say you are someone who is in the early stages of a bile duct cancer, and your goals are to really make the best of all the treatments that you have, and while living an active life through all the treatments that you're getting. Palliative care teams can work with the oncologist to do that. But let's say that you were diagnosed very late and you know that cure is not an option, but you're really afraid of what the next steps are going to be. And you really have taken some treatments, you know that these treatments aren't working. They're in fact causing a lot more harm to you, not only physically, but psychologically. And you don't want to take these treatments anymore. Sometimes you may be afraid as a patient or a family to have that open conversation with your cancer doctors. That's where the palliative care team and the palliative care physicians can come in. They can actually work with you, align themselves with you and your goals of care, and then bring the rest of the team in to discuss really what your options are and what you'd like to see going forward. So they sort of become your voice for you when you are afraid to speak up. They work as your advocates, they work as your partners, and basically they support your family as the family is also grappling with this issue. So I mentioned earlier, quality of life is huge for palliative care, and all comes down to that. If you don't have a good quality of life to the best of what can be done given your disease, then palliative care is going to work very hard to get you there. And so when I look at palliative care and quality of life, I look at it as two things. There's that individual quality of life of the patient, right? But I also see a collective quality of life where you have the patient and really everything that surrounds the patient. You have the patient, the family. If the patient has kids, that becomes a huge aspect of quality of life. And so which parts of the palliative care team can you bring in to really address all these issues to make sure that everyone is experiencing this journey without additional stress or anxiety and with clarity and transparency? How many times have you, and even I've had my own family members that have had serious illness, go to a doctor and really not understand what the doctor's saying to them. Everyone, as medical doctors, we are infamous for this. We talk in medical jargon. That does not help when you're already dealing with something like cancer and you're having to hear the words that I have cancer. That's when the palliative care teams can come in again. They can talk to you and explain things really in a way that you will understand them, and they can actually talk to the primary teams to really ensure that they are also communicating with you at the level that you need to understand. Because when that communication is broken, you can make decisions that are not informed. You can make the wrong decisions for yourself or your family members. You can choose the wrong treatment plans because you didn't understand it well. So it's really important to bring people that are going to be simplifying things for you. So this was the old model of palliative care. You know, back in the time when palliative care started, they used to only provide palliative care really towards the end of life. And that's why a lot of times palliative care got sort of misunderstood or confused with hospice care or associated with death. I remember when I was going into palliative care to train in palliative care, I had a family member ask me, why do you want to just treat death and dying? And I had to make a conscious effort of explaining really palliative care is very different than hospice or end of life care. As time evolved, you saw that, you know, the importance of palliative care was proven through research and by patients really even experiencing the benefits for it. And it changed the trajectory of how palliative care was looked at. So now you'll find in most centers, palliative care is involved early in the process, and palliative care teams walk the journey with you and help guide you through all of it if you need the help. If the journey ends up with cure, that's amazing. But if the journey does not end in a cure, they actually guide you through the next steps of looking at what end of life or the terminality of your disease looks like. So these are the factors that contribute, in my opinion, really to quality of life in the face of cancer, right? You have physical factors really from the illness and the treatments, how cancer is affecting physical function. If you have other diseases like diabetes or obesity, how are they affecting your quality of life, especially if you are older? How are they affecting you in your care for your bile duct cancer? Then you have the psychological and emotional factors, anxiety, depression, just having to deal with the fact that you have cancer and your life as you knew it before this diagnosis has changed. How do you deal with that? How is that affecting your day to day? Is it making you more angry, agitated, fearful? Have you just gone into a shell and stopped talking to your family members? Is the disease defining you that you can't enjoy a day-to-day life anymore? What are some of the social factors, that we look at when it comes to quality of life in palliative care? Really, what is the possibility with your disease state or with your loved ones having this cancer to have a working life, difficult in social relationships, financial hardships, treatment options, the amount of forms that you fill out to even to do an FMLA? That all affects quality of life. And that's where your palliative care teams can come and work with you and provide that layer of support for you. So there is an importance here. There is a balance. You have the symptom burden if you're the patient, right? Coming into this. And then on the other side, you have poor quality of life with all the stressors. So if you can reduce the stressors and if you can reduce the symptom burdens, you can actually enhance your quality of life. And I say symptom burden here, not just for the patient, but I say symptom burden also for the families. As caregivers, we know that especially over COVID and over the last few decades, caregiving has its own trauma, its own symptom burdens, and caregivers, they need their own respite. What are the effects of really caregiving on how a caregiver can take care best to their knowledge of the loved ones who are experiencing cancer? That's where, again, the palliative team can come in. They not only provide support for the patient, they provide coping strategies and help for patients and the caregivers aren't neglected either, because if your caregiver has a poor quality of life, the people that they're caring for are certainly going to have a poor quality of life. And that's something that you don't want. So like most cancers, bile duct cancers have also many symptoms, right? And some of the symptoms that palliative care physicians or doctors that specifically train as palliative care doctors can treat are pain, nausea and vomiting, constipation, diarrhea, bowel obstructions, fatigue, shortness of breath, anxiety and depression, weight loss, poor appetite, mouth sores, skin changes, hair loss. And the reason we get called in by the oncology teams is because we get a higher level of training in how to manage these symptoms. We have a few more tricks up our sleeve that we can use and work with the oncologists or the other teams, whether it's radiation therapy or the radiation oncologies, to work with the patients on these teams. Not one glove fits everyone when it comes to cancer. Everyone reacts to treatment options differently. So we as palliative care teams have the time to spend with you and your loved ones to really figure out what will work best for you. And that's where really palliative care team can be seen to do what it best can do. Now, the other aspect of palliative care is that what happens when really cure is not an option. If palliative care teams are involved early in your disease trajectory, they have walked the journey with you. They have understood really what your likes are, dislikes are, where you sit on certain treatment options, what your goals of care are. They will be the best transition team to take you from that treatment option ending and transition you to the next phase of your disease process and the last phase of your life. That would be the end of life care piece, the hospice piece. People don't really become eligible for hospice care until you're in the last 6 months of your life. You need that prognosis. And some of the aspects of palliative care teams are that these teams are also trained in hospice care and end-of-life care. As physicians, especially, we train in both hospice and palliative medicine, so we can transition people smoothly. What happens many times is that when patients don't have a curative option, they're often told about not having the cure or being in that last 6 months of their life many times right when they hit that 6-month mark. And at the same time, they're told about hospice care, which becomes extremely overwhelming, no matter who it is, whether it's the patient or the family or their children. And that's the other advantage of having a palliative care team involved. If the palliative care team is involved, they will guide you on this journey, and they will be transparent about what's happening to you right from the diagnoses to the end. There will be no surprises usually to a patient when a palliative care team is involved, and it makes people a lot more resilient. It helps them understand their prognoses. It helps them cope with what is to come, and it makes the end of their life a lot less fearful than those that don't have that option. So that, in a nutshell, is really a generalized view of palliative care that I hope you all take. If I had to spend more time on this, we could take hours and talk about this. But at the end of the day, palliative care's beauty is that it's customized to each individual patient and each individual family, and that's where it can benefit. So with that, I'm going to stop sharing and end the slideshow, and we can proceed on to questions if you have some.
Thank you so much. This was great. If anyone has questions, please feel free to put it into the Q&A or the chat. We do have a question that came up from a physician who's asking, how do we improve continuum of care for patients who benefit from inpatient palliative team consults, then discharge home on hospice care?
Absolutely. And Dr. Goodry, I know you and I are LinkedIn friends. I know you just read my article on hospice care with Ido Banak. So thank you for the question. Really, I think it comes down to our health systems incorporating palliative care into them early enough. So most of the times, what healthcare teams are also learning is that when you don't involve your palliative care teams when they're available early enough in the process, the transitions become very, very poor towards the end of life or even to hospices, right? Some healthcare systems like Kaiser have systems where palliative care is offered to patients within the 1-year prognosis. So whether you receive palliative care when you were inpatient or not, when the system decides, or when the prognosis is 1 year or less, they actually get palliative care involved, and you can get palliative care at home, which is different from hospice care because that's at the end of the 6 months, the last 6 months. So I think we need to look at really the models that are out there, the best practices that are out there. So specifically, I mean, involving palliative care teams early will help transition patients onto hospice a little easier than they are, because palliative care teams then have already informed patients about hospice care, about the services on hospice, about what the similarities are, about what more services they can get. And that's what I feel is the biggest issue when it comes to transitions, is that the communication gap or the knowledge gap that's missing often leads to people having sometimes really terrible transitions or really poor hospice experiences because they don't go into it with fully informed information about the resources. So I hope that answers your question.
We have another one. Our palliative care teams or specialists only available through hospitals, and do some hospice agencies also give palliative care?
So palliative care teams are primarily teams that work in the hospital setting. But like I said, hospice care involves a lot of palliative care, because what hospice care does, it just takes palliative care to the next level at the last 6 months of a patient's life. But the focus at that point is not cure, right? The focus is comfort. So you're looking at quality of life being everything focused on how do you enhance your quality of life in the last 6 months of life. That's why a lot of these physicians that work in hospice teams are also palliative care physicians, because they do exactly the same thing in the last 6 months of life. It's just that the goals of what you're doing or where you're reaching towards the end of that is different. So, medications might be escalated a lot more. If the patient's looking at, if they have symptoms that really are going to be symptoms that cannot be treated at home, you can have these hospice teams request people to come back into the hospital to get that treatment for the pain or the symptom for a bit, and then come back to the hospice at home. Um, they are actually doing a lot of the same things, and it's just that the focus is very different, and the focus is more on this patient is in the last 6 months. What is important to the patient? How can I focus on what the patient wants? And how can I make their last few weeks, months, days comfortable to the next life?
How does one access a palliative care team? Is it a referral from the oncologist?
So if you're at a hospital center, usually it is a referral from the oncologist, but many health systems allow really nurses as well as social workers or anyone else involved in the care to actually put in a palliative care consult. At our center, we have all these people really asking us for palliative care consults if they feel necessary. It doesn't have to be just the physician. Now, unlike that, when it comes to hospice care, it does have to be a physician usually that needs to put in the referral to a hospice agency or a hospice to evaluate you. But with palliative care, any team member can do it.
Okay, and then what is the best resource to join a palliative care team? I'm not sure if that means like social work, but
Yeah, so in hospitals, most hospitals have social workers working in their specific disease teams, or just have a department of social work. You can ask your nurses to connect you with the palliative care teams. You can ask your social workers to connect you with the palliative care teams. In fact, I would say you should even ask your doctors, your primary doctors treating the cancer, saying that, hey, I'd like to speak to the palliative care team because there are other aspects of my care that I would like to address. Many times people feel that they don't want the physicians to ask for palliative care teams because they feel like there's a loss of control there. Oncologists may feel that they're losing control. Patients might feel they don't want the oncologists to feel like they're losing control. But oncology is a specialty that does something very specific. Palliative care is a layer of support that can help patients and families really get the best of everything, and work with the oncologists on making sure that your goals and treatments are matched up. So it's really very okay for you. In fact, I highly recommend that you talk to your doctors to say, one, do we have a palliative care team? And if we do, can we get them involved just so that I can address other aspects of my life as I'm going through this disease?
okay. At what point should a patient request palliative care?
Palliative care can be requested at diagnosis, because I can tell you this, that even if your symptoms are not aggressive when you get diagnosed, the anxiety, the stress, the fears, the uncertainty, everything that comes with cancer is scary. And it would always be helpful to have someone else hold your hand and walk with you on that journey so that it does not become as scary for you, that you understand things clearly, that there is someone by your side to explain things to you when they're not clear or not in simple terms, or they just put in medical terms. So it really, there's never a bad time. I recommend my patients that come to my center, and we're primarily a cancer center, so I am a huge advocate to get palliative care involved early. And we've seen that when that happens, it's just easier on the families and the patients throughout their journey, whether it's curative or not curative. You can request them later. Just it would be that they would need some more time to get to know you. And it's almost like building that relationship and dancing that dance. So I think the earlier, the better.
Okay. For inoperable tumors, how will tumor ablation / alcohol injections be helpful?
So I think tumor ablation just destroys some of, when it's not removable, destroys some of the cancer cells there and remove some of the tumor that's in there to reduce the blockage. With alcohol injections, as I mentioned before, what it does is that it sort of, it desensitizes the nerves that carry symptoms like pain, signals to the brain. So when you're actually going to that root and numbing that source, it helps with not feeling the pain that you normally would. And that's, again, a palliative therapy that's usually done when really the tumor is not operable. The symptoms of pain are really so bad that even pain medications are not helping with it. At that time, you have to go down to the source and try and nip it right there.
How are the family aspects of palliative care billed? Through the patient's insurance or their spouse or parents' insurance?
I think it goes through the insurance agencies. We live in a complex healthcare system. I wish services like palliative care really weren't charged at all, right? I think it's a service that should be free for everyone that needs it. But mostly when it is done, it's done through insurance. And one of the things I've found is that in many cases, insurances need prior authorization from your oncology teams to get palliative care involved. So it's a good idea if you do have a serious illness, whether it's bile duct cancer or whether it is another cancer that your family member or you are facing, that you actually ask the insurance company ahead of time, because you'll be dealing with the insurance companies for a lot of things. So might as well ask them, hey, if we did get palliative care involved, what is the process and what do you need from us? So that you're clear when you do need it, that you have every information at your fingertips to get them on board as quickly as possible.
Okay. Since cholangiocarcinoma is a rare cancer, what are the chances that a palliative care team would be knowledgeable about this type of cancer? Are there different teams for different cancers?
So it all depends on the center you go to. There are some hospital centers that have really disease-based palliative care teams. So there's a palliative care team just to do cardiac stuff. There's a palliative care team that just does gastric cancers or just does neuroendocrine tumor cancers. So it all depends where you go to. The one thing with palliative care training is that they train palliative care physicians to really address almost every form of cancer and serious illness that there is. So we train in a versatile disease spectrum. If we are not capable of it, we will always bring in the experts. But I have found, whether when I've dealt with neuroendocrine tumors or bile duct cancers or even glioblastomas, that the training that we get prepares us adequately to work alongside the primary treatment team or the primary cancer team to address the symptoms. The important thing is here, we are not teams that are coming in to treat your cancer or look for a cure for the cancer. We are teams and we are physicians that come in to help with all the side effects and the treatment side effects, and help you with those. Those are very generic, and many times from that list that I showed earlier, many of these symptoms overlap in cancers. So it's usually looking at what's been done numerous times before that has always worked in this case as well.
Okay. Do you know if tumor ablation can be done even if stents are in place?
I would be amiss to say that I do because I'm not an expert. So I'm assuming, based on my general surgical knowledge, is that I feel it all depends on the location of the tumor, the size of the tumor, and the extensive spread of the tumor.
Okay. As a caregiver, will the care team allow the caregiver to be involved in the patient's care and dialogue?
Yes, and as long as the patient has either appointed you or has verbally told the team that, yes, you can have this person involved in my care. They can be my advocates when I can't speak for myself. The palliative care teams actually are very big about making sure that families and caregivers are involved, because as you know, many times there's discord or disagreements on treatment plans or other plans when it comes to goals of care, that can be different within patients and family members, or family members with other family members, and you have the patient and the physician stuck in between. So the biggest advocacy is to make sure that these palliative care teams get everybody on board so that everyone is actually making sure that what the patient wants is at the center of everything. And you come to a consensus around what that needs to be, and then go forward with one step.
Okay. Do you know if palliative care teams assist patients and the family, the caregiver, with the understanding about advanced directives and those paperwork?
Absolutely. So that's, again, when we do goals of care, when we do advanced care planning, it all involves that. And I think that's the beauty, again, of palliative care teams, right? You have physicians, you have social workers, you have chaplains, you have whoever you need to, you have child life specialists, right? If patients have kids. So when you have these teams, almost every member of this team is skilled in going over advanced care directives or going over the POLS forms, which are the physician's orders for life-sustaining treatment, going over the living will. They're very knowledgeable about these forms because that is an integral part about how you plan your treatments, how you plan your goals, and how you live your life while you're going through the disease. So it will be impossible for you to go through a palliative care team and not get asked, you have an advanced directive, do you want to sit down and talk about it? Let's talk about what you really want in the future. If you're on life support, what do you want happening to you? Are these treatments something that you want? Do you want to be taken off life support after a certain amount of time? Do you even want DN? Do you even want to be resuscitated? These are conversations that the palliative care team is very comfortable having. They know how to have them because, unlike many other fields, we have the time to spend with the patients and their families and to develop that relationship and rapport, so we can address it on that personal level rather than looking at it medically. And it makes it a much better way to have these conversations with you. I personally have not only had these conversations with my patients, but I've had these conversations with patients' loved ones who are 18 and above, and had them do advanced directives, because I think all of us need to do one.
So true. Thank you. If anyone else has any questions, I feel like we got through all the ones that came in, but if anyone else has any questions, please feel free to put them in the Q&A. There were a few thank yous to you for your presentation. For everyone who's on this webinar today, it has been recorded and it will be posted onto our YouTube channel, so you will have access to that as well. Doesn't look like any other questions are coming in. Dr. Banerjee, thank you so much for your time.
I am very honored. I am thankful and grateful to all of you. I will send my PowerPoint presentation so that you have that, so that you have the basics of what you need to understand. And I'm going to encourage each and every one of you to be advocates, to request really a palliative care team by your side. And if any of your physicians that are not palliative care physicians tell you that, oh, but you're not, no one's dying yet, I think with this, now you're empowered to say that palliative care is not for people that are dying. It's for anyone that's going through a serious disease. And having cancer is a serious disease that affects everyone's lives, not only the patients, but their families, their friends, and their loved ones. So you have every right to ask for the support. Okay.
Thank you. Those are the best words, I think. Good takeaway for sure. Thank you so much. We appreciate your time, and thank you everyone who was able to be on today's webinar.
Thank you. Take care. Bye-bye.
Bye.